And that is that, are we supposed to have double-stranded RNA inside of our cells? No. RNA should be what? Single-stranded, right? Yes. So there are mechanisms inside of our cells, and if you see double-stranded RNA, because certain viruses have double-stranded RNA. So we have these mechanisms designed to go after it, and if you see your cell detects double-stranded RNA, you have these molecular scissors that'll go in and chop it up. And now they're using it for medications or for therapeutic reasons. So let's say you have a cancer cell and you've got a mutated, well, let's just use bacteria or something. Anything, let's do a parasite. Okay? You want to help try to get rid of a parasite. And it's got a particular messenger RNA it makes for a particular enzyme it needs to survive. So to sort of make it quick and simple for you guys, you don't really need to know the whole mechanism. So if that's the RNA, what you can do is you can make a complementary strand to that RNA. And what's that going to do?
Make it double-stranded.
It's going to double strand to it, right? It's going to make it double-stranded. And as soon as your cells see that double-stranded, or their cells see it, what's it going to do? The mechanisms are going to go in and start chopping up that double-stranded RNA. And if you chop up the double-stranded RNA, do you ever make that enzyme? No. So that's how they use it more medically, but you can also use it therapeutically, things like that. You could do it, yeah.
So we don't need to know the name of those scissors?
No, it's called Dicer and there's RSC and a couple others. No, just know that it's another potential therapeutic tool that you can make these double-stranded RNAs. You can make a complementary strand and it will go in there. You can do the same thing with bacteria once it's uncoded, and not uncoded bacteria. Just know it's kind of what you guys be familiar with it because it's going to be not so much here and in antimicrobials, but it's getting pretty big in terms of therapeutics and things like that. So it's called RNA silencing. I just thought I'd introduce it to you guys, since it's in there a little bit earlier.
And he said it's RNA what?
There's a whole bunch of, there's RNAi, there's siRNA, there's microRNAs, there's probably a couple other ones out there too. They keep coming up with a new name like anything. So, all right. So we went through all this, right? Administration, we went through
yes. And I think we finished that one.
We finished this one, and we started talking about right here, right?
Yeah.
Wait, did we do the teeth one? We did the teeth one?
Which one?
No, that's the next one.
That's the next one? Oh, okay. Sorry.
The toxicity?
We talked about toxicity, right? We talked about toxicity profile, therapeutic index, things like that, right?
Oh, that is that one.
Okay, I'll go through, I got some more slides I can do that, I'll help show you that stuff. Again, you can take pictures, whatever I can post them. So, many, did we get to this? Did we get to toxicity at all? Okay, so we're going to start talking about toxicity. So these are safety and side effects. Again, anything can be toxic, it just depends on the dose, right?
Yes.
Thanks. Cause of any adverse effects are not really well known. Some of these things they're not quite sure, they just know you get too much of it causes problems. Some of them may have. You do need to know this. The main three sites of toxicity in humans are going to be kidneys, liver, and nerves. Why the kidneys and the liver? That's where you get rid of a lot of things, right? You metabolize them in the liver, and then you excrete things out through the liver and the kidneys. So those are going to be big targets for toxicity. Nerves also, why nerves?
It starts to affect the nerves, the peripheral nerve.
Peripheral nerve, even some of the other ones. You can get peripheral nerve damage. You can actually, if it can get across the blood-brain barrier or anywhere else, but they also can cause lots of damage in the sense of. You don't see a lot of damage to that. Doesn't mean it can't happen. But you ever get damage to your lungs, maybe? Mm-hmm. Sure you could. So there's some medications out there that actually can damage lung tissue with it. But the three main ones, especially for antibiotics, things like that, are going to be the kidneys, the liver, and nerves. Right?
Well, sometimes even when kidneys are damaged, it affects the lungs and the heart because of
Well, you talk to a lot of physicians out there. What do they say is the smartest organ in your body?
Ears.
Kidneys. They do so many different things. Think about what they do. They get rid of waste, right?
Mhm.
That's what everybody thinks of. They also regulate blood. They're the main regulators of blood pressure, right?
Mhm.
Water reabsorption.
So you messed them up.
And you mess them up. I had kidney stones. I don't even like talking about this. Consideration needed when prescribing drugs to pregnant women. Why?
Because it could affect the fetus.
Affects the growing fetus. If it can cross the placenta, it can cause damage. Those are called teratogens or teratogenic drugs. Did y'all ever hear of thalidomide? Not an antibiotic, but it's a classic example of a teratogen. You ever heard of it? Thalidomide? What do they use it for?
Morning sickness?
Morning sickness back in the 50s and 60s. Worked great. Except for developing babies ended up with maldeveloped limbs. We used to call them flipper babies because their arms would not grow all the way out. A lot of them didn't survive. So that's a teratogen. Now, the weird thing about thalidomide is, do you think they still use it?
Yeah, just not with pregnant people.
Yeah, it's actually come back and they repurpose the drug for something else. But one of the big warnings on there is do not give to pregnant women. Therapeutic index is the ratio, and we'll spend some time on this, the ratio of the dose of a drug that can be tolerated that is non-toxic to the drug's effective dose. That can be the therapeutic index or the therapeutic range. I'll go over a couple of those in a minute. Some drugs have huge therapeutic indexes. Benadryl. How much Benadryl can you take?
50 or 100.
You can take, I can take a ton of it. I used to have a Jack Russell Terrier that started having some intestinal autoimmune issues. For a while, we were giving her 2 full-size Benadryls.
Wow.
Now, she did nothing but sleep all day long, but it did not. It's got a huge therapeutic index. Things like lithium, they still use sometimes to treat bipolar disorder, has an incredibly narrow therapeutic index. And you have to be constantly measured on it.
What is Benadryl? Benadryl used for again?
Allergies.
The allergy, and it just means, yeah, so it knocks in, so it's suppressing her immune system. But you can take, you've just got a gigantic range before it's really going to do much. It's going to make you sleepy, but it's not going to do much else to you. Here are some other side effects. Kind of like this right before date night.
Damn.
This is an anti-parasitic drug that causes some of the iron inside of this mouth here to start oxidizing and gets inside of your little pathway down there. It goes away as soon as you quit taking the drug. What is this one right here? Nope, well, I think you got some plaque on there too, but that's not plaque. You ever heard of, when are you not supposed to give tetracycline?
To children.
To children before their adult teeth come in because it can cause this right here. And the problem with that is it is what? That's perfect. Okay. So here we're looking at some different targets. What does ED stand for? Oh, I put them up there. Not stand for what you think it is. ED is effective dose. PD is toxic dose. LD, have you ever heard of ED50s, EC50s, LC50s, LD50s? Okay, what they're looking at is the ED50 is going to be the effective dose where you get a response in 50% of the people you give it to. Okay? LD50 is going to be the lethal dose for at least 50% of the population you give it to. Okay? And then you can have your toxic dose for TB. The therapeutic index is going to be what?
In between ED and TB.
This is the concentration. You just divide the TD by the ED to give you the number, or you can sort of graph the range on there. The idea is, this is the therapeutic index. This is the point where it becomes effective at this concentration, and this is the point where it becomes what? Toxic. Now, if you have this one way over here, you would have a huge what?
Therapeutic index.
Therapeutic index. Sometimes they can be right here. In which case you would have an incredibly narrow one. All right. And again, this is kind of an easier way to look at it. Here's concentration going up. So subtherapeutic means what?
It's,
You're not maintaining that drug at a high enough concentration in the blood to do its job. Here's going to be a therapeutic range or the target range, and you get above that where you get to the toxic range. Okay, what can affect this too, guys? Inside the drug, a little toxicology into this class.
for a drug to reach peak concentration in plasma.
So, the time of drug to reach peak concentration in the plasma after extravascular administration is called the time of peak concentration. It is expressed in hours and is useful in estimating the rate of absorption. How long does it take to get to peak plasma concentration? That's the highest dose it's going to get in your blood, right? Then after that, it's going to start doing what? It's going to start going down, unless you're administering IV. Should be here. But certain patient demographic, pathophysiological and therapeutic features such as body weight, excretory and metabolic functions, and the presence of other therapies can regularly alter dose concentration relationships. What does that mean in English?
Considerations.
The different people, and they're finding out, didn't we talk about it before more, they're finding out more and more that people are very different, and these ranges have to be calculated more broadly than they used to think. When they talk about metabolic and excretory functions, what are they talking about? Liver and kidneys. How are you going to metabolize that drug? How are you going to get rid of the drug? Right? Down here. Steady state concentrated drugs eliminated mostly by the kidneys are usually greater in patients suffering from renal failure. Again, you have to be careful if you have liver damage or kidney damage. You're going to have to monitor and adjust the dosage of drugs. What else can affect drug metabolism?
Storage.
What's inside of a person?
Their food.
Another drug?
Another drug. And this is a big area of research now. It's called drug-drug interactions. How many medication is the average 50-year-old on?
A lot, several.
5 to 6 prescription drugs. So now they're having to look at all these drug-drug interactions, because you may go to this physician and get this drug, and you may go to this physician and get this drug, and this guy may not know what he's prescribing over here and over here and over here, which is why pharmacists are becoming more and more important in sort of this middle part of keeping an eye on all these drugs. But patients don't always tell their doctors what they're on.
Mm-hmm.
You ever hear of a drug called Seldane? I talked to somebody about that. You ever heard of the drug Allegra?
Mm-hmm.
What is Allegra? Does it have histamine? Back in the 80s, they came out with a drug, or 90s, called Seldane. Seldane is what they call prodrug. The drug does not become active until it's been metabolized in the liver. Then it becomes functional. So Seldane was one of those drugs. Didn't do anything until you took it and it got metabolized. Some people started dying. And they couldn't figure out why. So they went back and started looking at their profiles, and they were getting massive buildup of Seldane, the prodrug, in their system. And it wasn't being activated. And they went back and they looked at these people, and a lot of them were eating grapefruit.
I was going to say, yeah.
Grapefruit is one of the natural toxic substances out there that inhibits one of your drug metabolizing enzymes in your liver. So it was inhibiting that enzyme, that means it wasn't being activated, and it wasn't getting eliminated and built up to toxic levels. Now that drug is called Allegra.
Wow.
Allegra is the activated compound. So they took Seldane off the market and just made the activated compound.
A lot of antidepressants, too, are affected by grapefruit.
Some antidepressants are, and there's another one. There are some HIV patients, when they came out with the new protease inhibitors, and there was a subset of patients they were not working on. They couldn't figure out why the protease inhibitors were not working. And it turns out those patients were all taking St. John's wort. You all know what that is?
It's a
What
herb.
do you St. John's wort? It's an antidepressant. It's a natural holistic antidepressant as an herb. It doesn't inhibit the enzyme. It was inducing the enzymes. So now the enzymes are breaking down the protease inhibitors before they can do their job. So what does that mean to you guys?
Don't take herbal
All
remedies.
this interesting stuff I went through out there. What?
Don't take herbal remedies or eat grapefruit.
The biggest one are holistic and herbal remedies, and they're finally starting to put that down when the gastro doctors tell us everything you're taking, because some of those things can drastically affect metabolism.
But what I think is ridiculous is that they're not regulated by the Food and Drug at all. Like, they don't even look at them. Like, it's
Because
crazy.
they took a shortcut. They're saying it's not a drug. They say it's a supplement.
Yeah.
Right.
Like a
It's a supplement.
dietary supplement.
Yeah,
Like,
so they're not
that's how they
regulated.
get really.
I think they should all be
So
regulated
they
though.
come, yeah, so they sort of sidestep that. There's a couple private regulatory things out there that are at least trying to standardize
Yeah.
the concentration stuff. Because if you do that, you go out and you buy 2 pills full of whatever. The big one is that turmeric out there now that's real popular. How much turmeric is actually in there? How much of the active ingredient is actually in there?
Yeah.
You have no idea. They don't regulate it at all. But when you guys start seeing patients and stuff, drug-drug interactions and drug supplement interactions are going to be a big deal now because they're more and more and more. I can't believe the average 50-year-old is on 6 prescription drugs. That's insane. All right, allergies. Back with penicillin again. Where's penicillin come from?
Fleming.
Not from Fleming. It doesn't come from Fleming. Where does it come from? From a fungus, right? Penicillium. A lot of the older ones, before they made those semi-synthetics and things we talked about, original penicillin, a lot of people were very allergic to original penicillin. Even if you were allergic to funguses, they would sometimes hesitate giving you penicillin. Like my older brother, I've gotten rid of him. He's allergic to penicillin. So, maybe they're rare, but they can be life-threatening. What is anaphylactic shock?
When your airways close up.
Your weight goes up, you get hives.
2 different main parts of anaphylaxis, how it can kill you. That's the slow and painful way, right? Your airways get all inflamed, they fill up, you can't breathe. If it gets really bad, you can suffocate, right? What is the other way it can kill you?
Muscle.
Go ahead.
It shuts down the muscular.
Not that so much. This one's real. This one is people do.
What is that?
Hmm?
Does it affect your
Nope.
blood?
Hmm?
Your blood?
What about your blood though?
Like clotting or something?
Not clotting. One thing that anaphylaxis can do, what do those histamines do a lot of times? What are they called? They cause vasodilation, right? So you get a massive release of anaphylaxis, and every one of your vessels in your body dilates all at once. What happens to your blood pressure, people? What happens to you?
You drop. You drop.
Go right down there with them. Fortunately, that's even rarer than the other one. I have a nephew who's kind of allergic to shrimp, so we always sneak little bits into his thing. And all he does is his mouth gets all red and he's
Oh.
Who's that?
Hmm? No, we don't know you. We didn't want you. We always threatened it. Okay, disruption of the normal microbiome results in secondary infections. We already talked about that. Secondary infection, overgrowth of normal flora causing super infections, or, that's why I said they kind of overlap. What did I say is the other one for secondary infections? So overgrowth are super infections. Secondary infections are what? They kind of overlap depending on what
Well,
organism it is.
I just know like there's some other kind of virus bacteria kind of goes in and infects the same.
Something is more of an
thing.
opportunistic pathogen, or something happens and it loses that competition, and so now it causes a secondary infection in there. Difference is, super infections is already there, right? C. diff, anything like that. Secondary infections, remember, it's something that's not normally there, or it's a transient organism that's coming across. Okay? Why is this the greatest concern for hospital patients?
Because like after they've done their like surgeries and stuff, there's like a lot of them can get the secondary or the super infections because like if we're in hospitals, like everyone's sick from something.
I think because their immune system is compromised at that
Well,
point.
why are hospitals just the perfect storm for this whole thing now?
Stress.
Not just stress, but why are they the perfect storm for all this huge issue? I mean, I won't get I'm not going to a hospital, guys, unless I'm dying, because odds are you're going to die in a hospital anyway. So I'm not going to get near one.
I mean, like the hospitals are full of everyone who's sick with all these different diseases, and some of them you don't even know. And then there's like waste going around from surgeries.
The two biggest problems is, like you guys were saying, almost all patients who are in the hospital are at least somewhat immunocompromised, either from stress, steroids, post-surgical immunosuppression, they get stress from that, they're on some sort of drug that's causing immunosuppression, so they're already in trouble, right?
Mhm.
Secondly, by constant use of antibiotics in hospitals, they are eliminating the susceptible organisms and they are positively selecting for the resistant strains.
Like MRSA.
MRSA, VRSA, VER. That's one you guys don't hear about much anymore, but it's a big one. Vancomycin resistant enterococcus. It's a VER. Oh, VRE, I'm sorry. VRE. Vancomycin resistant enterococcus. What's C diff? I'm talking to the intestine. When I was talking to one of my students down there, oh, we see C diff all the time. It's not that big of a deal.
That's
Yeah,
what I
you
heard.
sound like
That's
that.
what I heard too.
I'm like, really?
If you got it, then it's a big deal.
Mhm.
If you have it, then it'll be a big
It is
deal.
a big deal, and the problem with C. diff is it's also becoming very resistant to the antibiotics. So all of the stuff inside of your gut, has anybody here never been on antibiotics?
Okay.
Yeah, you don't see that. You never? Ever? Are you serious? Well, you're the only one. Your gut's probably in really good shape. Most people, just by virtue of being on antibiotics, you're already doing what
Killing.
to the stuff inside of you? You're not killing them.
Altering.
They're becoming more and more resistant already to a lot of the antibiotics because you're sort of selecting for those resistant ones. Okay, now we're going to talk about resistance for the rest of the day. Some pathogens are already naturally resistant. We're going to talk to the ones that were called later on. A lot of the ones we call opportunistic pathogens, just because they're kind of hanging around all the time, have already become naturally resistant. Some of them are naturally resistant, like gram-negative, because of that outer membrane, right? How do you get resistance in bacteria? Two ways. One are just going to be mutations. You have a random mutation in there. That mutation, for whatever reason, causes resistance.
Resistance like to the drug or?
To the drug, to the antibiotic.
So you have the antibiotic and then the bacteria is taking over? Or?
Well, so you've got a bacteria that for some reason gets exposed to UV light, gets exposed to some mutagen, and it just develops, it just has a mutation in its chromosome that develops resistance to a particular drug for whatever mechanism. We'll talk about the mechanisms in a minute. But that's just part of evolution, right?
Okay.
And the problem, I'll show you why that's a big problem in a minute. But that's just one of the random evolutionary ways it happens. The other way it happens is what? Acquisition of R plasmids, which are called resistance plasmids. Either transformation, transduction, or conjugation. And this is where, like I said, they're like Pokemon cards. Some guy gets a resistance plasmid, and he goes to his buddies and says, here, I'll trade you this one for this one. Give me a vancomycin, I'll give you a penicillin. Give me a colistin, I'll give you a streptomycin resistant plasmid. So I'm going to bring this right now because this is what I was talking about. This isn't in there, you can just write this down real quick. What is the difference between a true pathogen and an opportunistic pathogen? We'll get into this, we get into bacteria later on. True pathogens cause disease in healthy individuals. If I were to not cook my chicken, well, chicken, and it had salmonella on it, are you going to get sick? If there's enough in there, you're going to get sick. Salmonella is going to make you sick. Okay, it's a true pathogen. So it's associated with a specific and recognizable disease. In this case, it would be what? Salmonellosis. What's the symptoms of salmonellosis? Not systemic. Just we'll talk about systemic later on. Salmonella can actually get inside of you. Come from. If you get salmonella, what are you
gonna get?
What are you gonna get?
Diarrhea, vomiting.
You're gonna have diarrhea, but it's mostly
Fever.
diarrhea, and you're gonna be miserable for about 3 days. Now, here's a quick question: should you take Imodium to stop that?
No, because you want to get rid of the disease.
Yeah. The whole idea with things like salmonella, they're called self-limiting diseases. Your body's saying, I need to get this out of here. If you clog yourself up, they're going to be in there going, we get to hang around for a little bit longer. Now, if it's really bad, doesn't put you on antibiotics, but it's self-limiting. Opportunistic pathogens cause disease in immunocompromised hosts. Gain access or injury to a sterile region. So one of these two things like this. either immunocompromised or they get somewhere they're not supposed to be. And we'll talk about some of those later on in the kidneys. People want catheters and things like that. Some of those are opportunistic pathogens. But the problem with opportunistic pathogens, a lot of them are already resistant to several antibiotics. So they don't normally cause disease, but when they do, it can be really bad. All right. So here's the mechanisms we talked about. Oh, look at these. We'll cover these in a lot more detail later on, transduction and conjugation. Transduction is you have a bacterial phage that infects the bacteria. They're making tons and tons of copies of themselves, right? And when they're doing that, they're picking up and they're loading up their viral genome inside of the head group up here on these guys. Well, somebody made a mistake, and instead of putting viral DNA into this virus, they put what into it? They put bacterial DNA inside of that virus. Okay? And if this happens to be a resistance gene, the cell lyses, these guys go on to infect other bacteria. This little guy lands on a bacteria, injects its DNA, does it have the information to make more virus? No. So is it going to kill that bacteria? No. But it just introduced what? Some resistant DNA into that bacteria. This is conjugation with plasmids. So you've got a bacteria that's got an F plasmid in it, multiply, whatever they want, there's different names for them. And let's say it's got a resistance plasmid in it. Okay? It can make a pili. Now it's going to have this conjugation. It's going to copy that plasmid, and it's going to do what?
Give it the resistance.
It's going to transfer it over to this one. So now this bacteria is just what? Two things it has done. It's taken up a resistance plasmid, and usually it gives it, if it doesn't already have it, the plasmid to make a pili. So now what can this bacteria do?
Same.
It can go on to another bacteria and pass that on again. Then it can go on to another bacteria and pass that on again. And there's another mechanism called transformation. And that certain bacteria can actually take DNA out from the environment. So if you're throwing all your antibiotics down the toilet, are you supposed to do that? No. What are you supposed to do with your used jugs? Don't let me tell them, I don't want to know. No?
Take them back to your doctor.
Take them back to your doctor. The DEA twice a year has a drug, I don't want to hear what's the other way you can do it? Really works well in El Paso. They tell you to get something like old coffee grounds, dump them into the old coffee grounds or old cat litter, and just put them in the trash. And they'll get put in there and they'll get broken down and get in the trash. They're not going to go in the water table at El Paso very much. But the idea is they don't want people rummaging through the dump out there looking for medications.
I have a question. Once it creates the pili and then starts creating, can it only do it once, or can it just continuously do it over and over and
If you
over?
got that information to make those pili, because it's kind of like a fimbre, right?
Yeah.
It's just a projection that can grow out there.
Okay.
This is another one. Pretend this is somebody's throat. Okay? One of the big problems with people not in compliance with antimicrobial therapy is what's wrong with this guy's throat. He's got strep. Most of the time you have at least some resistant bacteria already as part of your infection. It's just a part of life. Okay? You start taking your medication, what are you killing off?
Kill off the...
The drug kills off the susceptible ones. If this was your throat or any other part of you, the idea is now your immune system is usually able to mop up the rest of the organisms. You've knocked down the infection where it's not that bad, the immune system can come in and take care of it. Okay? Same thing like bacteriostatic drugs work. But if you quit taking the drugs, what happens? So now this person quit taking their medication right there. 4 days into the treatment, they feel fine, the throat doesn't hurt anymore. They quit taking the antibiotics. Now what happens?
It regrows like resistant.
Start to get the infection starts coming back, but in this case, every one of the bacteria there is now what?
Resistant.
Resistant to that drug. So this is another way you're starting to select for resistant organisms. You're getting rid of susceptible ones, and you're doing what?
Leaving the resistant ones.
It's called positive selection in the lab. You're positively selecting for things that can resist those drugs. This happens at hospitals and nursing homes all the time. And this is my little thing I put together. makes a little pili, makes a little plasmid. Whee! I was really bored this morning. Now what does this guy do?
Transfer results.
But kind of cheesy, I know. But it kind of shows that you go from organism to organism to organism. The key to this does not have to be the same species of bacteria. All right.
Oh, crazy. That's crazy. It doesn't have to be the same species.
That's the problem. That's one of the scary things about it. Okay, how do we get 7 mechanisms? I want you to know these guys. Production of an enzyme that destroys or deactivates the drug. Okay? What is the one drug I talked about at the beginning of the semester? Beginning of this chapter? Man, you crippling yet? What do those beta-lactanes have? What do all those beta-lactane drugs have? They have that beta-lactane ring. Remember that square little ring? You all remember that? Okay, trust me, they all have that. Go back and look at that later. That's what the part that binds to the enzyme that puts in that tetrapeptide bridge. Beta-lactamase. It says mace at the end, it's an enzyme, right? Bacteria produce beta-lactamase, it cleaves this ring open. Once that ring is cleaved, it can no longer bind to that enzyme, and you have effectively gotten rid of the effectiveness of penicillin. Okay. That's production of an enzyme that destroys or deactivates the drug. Enzyme goes in there, cleaves that beta-lactane ring, and it's done. You can take enough penicillin to kill a horse, it's not going to do you any good.
So that's what penicillin does.
No, this is what beta-lactamase does.
Okay.
Beta-lactamase is the enzyme produced by resistant bacteria that cleaves that ring in penicillin, so it can no longer bind to that enzyme. Okay. Slow to prevent entry of the drug into the cell. If you can increase your cell wall, if you're gram-negative and your membrane on the outside can keep the drug from coming in, if it can't get in, it can't do what?
Work.
Can't do its job. Biofilms can do this too. Alter the target of the drug so it binds less effectively. You may not completely cleave this beta-lactane ring, but if you can maybe distort its shape a little bit, is it going to be able to bind to that thing as effectively? No. Or to a receptor.
Wait, altering, that's the biofilms, or was the biofilm the slow?
The slow and prevent. Yeah. Alter the target of the drug so it binds less effectively. So, well, actually, this is the target. So if you have this enzyme, let's say this is the enzyme that puts in that tetrapeptide bridge, right? Everybody follow me on that?
Yeah.
And beta-lactanes bind right here, and this is the active site. So that's going to prevent it from doing what?
From binding.
From adding in that tetrapeptide bridge, right? Well, if you alter the shape of this target a little bit, so now the active site's kind of over here, can beta-lactane attach to it anymore? No, so now you just change the shape, so now the drug's not going to work. That's that one. You can read that right when I look at it. You understand the difference between those two now? Okay. Alter their own metabolic chemistry, and I'll show you an example of this one in a minute. Pump out antimicrobial drugs before they can do their job. Those ABC transporters, the same thing that causes chemotherapy resistance in humans, can cause antimicrobial resistance in bacteria. If you're a bacteria, you have these pumps that pump things out. Same thing with cancer cells. You start giving them too much antibiotic, they start making more and more and more of these pumps. And if you make more and more of those pumps, what are you doing?
Pumping it out.
You're pumping the drug out faster than it can do its job. Same thing with one of the main reasons of cancer resistance. Okay. Again, this goes back to biofilms. So bacterial biofilms can resist antimicrobials. Usually it's going to be back up to that one.
And we don't have drugs to stop the formation of those pumps?
No, I actually didn't. I did a whole bunch of, this is my whole dissertation. He's working on that in cancer patients. It's not as easy to look, yeah. There are some out there they're working on, but Okay, don't worry about this one right here. I'm going to cover tuberculosis when we get to it.
And that's the last
So
one.
just know the sick. Yeah. Okay, here's some mechanisms right here I was just talking about. Here's penicillin. It's got a what? Got the beta-lactam ring. Beta-lactamase comes in, cleaves that ring. Penicillin now what?
Inactive.
Inactivates it. Okay. Now, remember the sulfur drugs we talked about? They bind the sulfur compound is going to bind to this first enzyme, right? It's going to inactivate that enzyme, so that means no what? No dihydrofolic acid, which means no tetrahydrofolic acid, which means no purines and pyrimidines, which means no what? DNA and RNA. So what have bacteria done now? Fine. Shut down that enzyme. I'll just bring in dihydrofolic acid in from the environment, and now what have they done?
Wow, created its own pathway.
It just got rid of this whole part of this pathway, and it started here. And that means those sulfur drugs will do absolutely no good. So it's altered its own metabolic path process to sidestep the drug. All right, now, what's that drug out there? Is it Clamomox? Is that the one that's got 2 medications in it? Anybody know? Or is it the Z-Pack? Which one has? Z-Pack is erythromycin, right? Is it does anybody know Clamomox? Is that the one? It's got 2 drugs in it. Have y'all seen that? It comes in a pack. Let me look at it. But what they're doing now is, in addition to the beta-lactam, they're adding another drug that inhibits beta-lactamase. So now what have you done? A little bit of thinking going on here. What have you done now? So you're worried that the bacteria that you're trying to treat is resistant to penicillin, that it produces beta-lactamase. So now, in addition to the penicillin, you add a beta-lactamase inhibitor.
So it increases the how the antibiotic works. It's helping it, boosting it.
But how is it helping it?
By stopping the lactamase from.
So now you're outsmarting the bacteria in its own game, right? It's going to make beta-lactamase and inhibit your drug? Fine. I'll just give you another drug that inhibits your enzyme, and now this drug is going to start working again. All right, let's go through these. We're only about 5 minutes. I don't want to get through this whole thing. All right. Multi-resistance and cross-resistance. Remember I said they can acquire more than one plasmid. Common when our plasmids are exchanged, they pass them around. And what did I show you here? This kind of sums a lot of this up. Development in hospitals and nursing homes, because you are constantly using antibiotics, so you're constantly selecting for resistant strains. Okay? MDR are pathogens that are resistant to at least 3 antimicrobials. XDR is, I think, 5. There's an XDR tuberculosis out there. I think there's only about 5 or 6 drugs that treat TB effectively. There is a strain of gonorrhea now that I've talked about, I'm sure have I, that is resistant to every known antibiotic. So know what multi-drug resistance is. Cross-resistance may develop to similar though novel drugs. So if you make a big wide spectrum beta-lactamase, you may be able to do what? Be resistant to every one of those drugs. Every one of those beta-lactams. Anything that's close to it. Okay? So that's how you do that. Now, how do you get over resistance? Or how do you prevent it? So the main way is what? Maintain a high enough concentration of the drug in the patient for sufficient time so you can kill off all the sensitive bacteria and keep the infection knocked down until what?
For your body to fight
the
it.
immune system can kick in and take over the rest of them. Because even the ones that are resistant are going to be sort of affected a lot of times. Use of antimicrobial agents in combination. This has become a new popular way to do it. Instead of giving you one antibiotic, they'll give you combination antibiotics. They'll give you a protein synthesis inhibitor. They'll give you a cell wall synthesis inhibitor. and they'll give you something else, kind of like they do with HIV. The idea behind that is hopefully the bacteria are resistant to all those different types. Problem with that is they become incredibly what? Drug companies love doing this. Because they, according to the patent laws and everything else, if they take penicillin, tetracycline, and something else and put them in a new drug, they have a new drug. And so they can charge you a new price for it.
Wow. So even just combining things that are already out there, they can.
Yeah, it's pretty sneaky.
That's
But,
crazy.
And I do that when I tell my, my friend, he goes, oh yeah, here, give you this antibiotic. I'm used to paying $5 to $10 for antibiotics. $125.
What?
Okay, what is synergism? And antagonism, we know. The problem is, sometimes you'll take drugs, like I talked about those drug-drug interactions, they'll actually counteract each other. But synergism is what?
They work better together.
Did we talk about synergism here already? Did I bring it up? Yeah. So that's what they're showing here. So you get this zone of inhibition, this size with this drug, and you get it this size with this drug. You put them together, and what happens? Bam. We already talked about this. Only use antimicrobials when you need to. And then development, you'll see about this when you guys get in hospitals. They call second generation drugs. These are semi-synthetics. Third generation drugs, they've done something else to them. They make them more and more efficient. And the search for new antibiotics, semi-synthetics and synthetics. Like I said, I'm not here today. If you want to have an interesting job, go sign up to go look for new natural antibiotics out there. They're looking all over the place for them. And this, what are you looking at here? A lot of these are antivirals, right? They'll give you an analog drug, something that's close to the shape of an enzyme that's going to inhibit it. What are these bacteriocins? They're not antibiotics. They're small little what? They're small little peptides produced by bacteria to kill other ones in similar species. And this happens inside your gut all the time. So they're going back and looking at those as possible antibiotics now. And what is the other thing I said they're looking into reinvestigating for antimicrobial therapies? Guys remember? Because the Russians were still doing it. They've been doing it the whole time. They're looking at bacterial viruses now. Remember? Talked about that? Yeah, you didn't bring that up at the beginning, yeah? Those bacterial phages, a phage is a virus that affects bacteria. Are you a bacteria? Well, there you go, man. The rest of them, right? That means they don't do anything to humans, they can't infect humans. They started using those back in the past. You got a big cut, it gets infected with staph, you put the bacteriophages on there, they grow and multiply until all the bacteria are dead, and then they go away. So they're starting to come back and look at those again. They're also talking about, it's pretty neat. They're also talking about using them as food preservatives for listeria. So you take all the deli meats and you sprinkle them with bacteriophages that are going to kill the listeria. Is it going to hurt you? Are you going to taste them? No. All right. Right on the front.